All right, so we're going to keep going, and most of us think radiation is bad. The next guy makes a living out of radiation. Brian Butler is basically the chair of radiation oncology here, and has been the amount of imaging that they utilize to pre-plan the procedure is just simply amazing.
Well, I want to thank Dr. Lumsden and the committee for inviting me to speak today. I've been here since at the Houston Methodist Hospital since about 1990. Alan Lumsden came over a while back after that, and I hadn't met Alan. He came over for being in charge of cardiovascular surgery, and I've met him for the first time in a meeting room, but I really didn't meet him personally, but I heard this guy talking. And I said, oh my God, I just had watched Braveheart, and it sounds like William Wallace. So to say the least, Alan has done a great job of uniting all the imaging and surgical fields together in sort of a focus group to understand what everybody else is doing. So lots of times the best solutions from things can come from people outside your field. And so of course from radiation therapy, we've learned a lot from surgery. So at the other time, I've seen Alan in rare form when he's asking for equipment at the technology meetings. And he's always asking for CT scanners or a DynaCT. Well, in radiation therapy, we've been using CT scanners built into the machines, cone beam CTs, and sophisticated for imaging for about 10 or 12 years. So the question is can you use radiation oncology sort of thought process to do surgical planning? Now, the most important thing in radiation therapy is the target doesn't move. So we have these very sophisticated immobilization devices so the target can't move. But once you go outside the head and neck area, of course, there's going to be organ motion. So how do you account for organ motion outside the head and neck area? Well, there's no better place to control organ motion or the respiration than the operating room, because we do a lot of things in terms of tracking the patient's respiration, and we try to hit a target in the lung, or we try to hit something else. And what we do is basically what's called a 4D scan, and we bin the data into 10 different phases. And I say, okay, I know what phase I'm in now. I'm going to hit it with my beam now. So if you think of the radiation beam as sort of a scalpel, that's sort of our thought process. And we can hit something within a millimeter or two. So for instance, you just heard Dr. Zhang talk, and sometimes he'll call us about a patient that may be that has a AVM in a very eloquent area, and he can't do surgery, and he says, can you sort of ablate this with radiation therapy? So now you hear these terms, stereotactic radiosurgery or gamma knife. Think of it being like a surgical tool in the sense it's only one treatment, but massive doses of radiation therapy at the time. So you better be able to hit the target. So we better make sure the patient isn't moving, and we better be able to hit the target. Now, all images have an XYZ coordinate system. So if we put the patient on a table, we should be able to hit any point in that data set or that patient with our beam within a millimeter or two. So the idea is, how about, well, you're just using CT. Well, you can also, what we've done is develop sophisticated tools to be able to take because an MRI scan often will tell you more information than a CT scan, which will tell you, and then you can fuse the PET scan and all the data into one location to define your target. So the idea is because what you do in surgery is put a patient on a table, and then hopefully in the same spot, if you have that data set, you should be able to hit a target within the patient as long as the patient's not moving. We don't have the luxury of having the patient under anesthesia, so we have to monitor the patient's motion at all times. So I guess the question is can we use some radiation therapy principles to hit a target within a patient, or even hit a volume within a patient, and watching that volume move and how much of that volume? And can we subsequently, if we know where the target is, just like in radiation therapy, we say, oh, here's the target, and I'm not allowed to hit the kidneys, I'm not allowed to hit the spinal cord, I'm not allowed to hit this blood vessel. Put it into the computer and say, these are my constraints. This is what I'm allowed to hit, and this is where I want to paint my dose. So the computer comes up with an algorithm. It's typically an algorithm called simulated annealing that says, okay, I'll tell you where the best target angles will be to hit that target. Well, can you do the same thing in surgery? Say, okay, where's the best flight path to hit a target, especially now that surgery is not doing open up all the time, you're going through different parts of the body. So just like in what Dr. Catano was talking about, was that you have to understand where in space things are and what if they don't align. So before we treat a patient every time, we image the patient to see where in space they are and whether we're going to be able to hit that target. That information is connected to a table that has 6 degrees of freedom. That can move in and out, right and left, pitch, yaw, roll, to make sure we're locked in at the right spot before we give this big dose of radiation. So the other thing we want to do is say, okay, we typically, radiation therapy treats patients on the back in one same location, or supine or prone. Well, what if you took a patient and you rotated him several degrees and moved structures out of the way, like move bow out of the way? So up and you're all going to see the mighty later on. If you go into the OR suite, you'll see a table up there. It's a famous table because it's called the Trump table of the Trump Corporation, not Donald Trump. But it can rotate at multiple directions. So we acquire data and say, can we come in at a better angle to hit a data set or a point within the patient's body? So we have all these tools up in that room to say, is the patient in the right spot? We have laser lights on the wall to make sure the patient's in the right spot. We also have a camera that you'll be able to see in the room. It's a stereo camera that will tell where the patient is and where they should be from their original data set. So let me just go on here. So radiation therapy's job is to hit the target and remove it by ablating it with radiation therapy and minimize tissue to normal structures. And we have, instead of big beams in radiation therapy, we have typically 40 little beams that can turn on or off for increments of 10% every 5 degrees of rotation. Now we have like 2 times 10 to the 7th fields to be able to hit our target with this radiation beam. The goal of surgery, of course, is to remove whatever structure you need to remove and to minimize damage. As I said, we got to be able to immobilize the patient and track the patient, create sort of a personalized coordinate system within the patient's body. So what if I could scan your body, reconstruct you in 3D, and tag and label everything in your body? Because then when I enter the data set with an instrument, I should know exactly where I am in relationship to these critical structures, so you can almost have a warning. And there's ways to detect where the tip of that needle is by signaling devices and other things, magnetic devices, all kinds of things. Now, what we do in radiation therapy, we account for error, from not understanding, because we're dealing with tumors, exactly where that margin is, and also from the respiration by saying, okay, this is where I see the target on the image, but I know it may be slightly bigger, especially cancer, not necessarily vascular malformations. And so we grow it. We say, okay, let's make it bigger to make sure we don't possibly miss where the fibers of the tumor can be. We also grow normal structures to give us additional protection to make sure we don't hit a target. In every radiation therapy department, there's a CT simulator where we get our baseline data set, immobilize the patient, put them in sort of a bean bag, pull the air out of it, make sure they don't move. And that data set is our XYZ coordinate system. Then we put them on the table to treat them. There'll be a CT scanner there to register the patient and make sure we're in the right spot. Treatment planning algorithms, there's a number of sophisticated algorithms to account for things as our dose hits the target, just like the algorithms we like to try to create in a surgical treatment planning system. For instance, in a CT scanner, there's Hounsfield numbers. Those Hounsfield numbers may equate to resistance as you come in with a needle or an instrument through the patient's bodies, gives you additional feedback of where you are located within the patient. So for instance, for us, going through air cavities creates a different dose distribution than other things. And we have to account for all those things, just like you would account for things in surgery. You do a 4D scan, look to see how much organ motion there is. Again, in the operating room, you're on a respirator. There's a possibility of doing things like high velocity ventilation where there wouldn't be much motion at all, be able to minimize your target motion, or being able to hit the target or come into the target with a needle during the right bin of the respiratory cycle to hit that data set. So like I said, you can control the respiratory cycle better than we can. We have an MRI scanner in that room up on the 5th floor. So now you have data sets. You have all the data set creators or the GPS system creators or to evaluate the patient. And the same type of thing we do in radiation therapy is what's called adaptive radiation therapy. What if the tumor shrinks? Well, the data set has now changed. What if you take some of the liver out? Then the data set has changed. You have to re-image the patient and re-register the patient because your flight path may now become different again. So we're trying to develop ways to evaluate organ motion if you're going to create a system like this in the operating room to understand where data is within this data cube of the patient after it's been tagged and labeled. So the most important thing we do in radiation therapy is set the patient up in the same spot every single day, 5 days a week, to make sure we hit that target. We do the same thing, same operation, 5 days a week for 6 weeks. You do one operation, so immobilization and know where the data is becomes important. Just like that patient with the AVM or the solitary brain metastases where we give one shot, creating a feedback loop of understanding where we are volumetrically re-imaging the patient and changing the 6 dimensions of the table as automatically we'll just register the patient, say this is where you are off, and it will move the table into the right spot, and then you image again to make sure it is correct. So most important thing, of course, for us is evaluating in the head and neck area in the brain. It may be a little easier because you don't have so much organ motion. You're going to mobilize the patient with the gamma knife and other things. Typically, sometimes we'll put a big head frame on the patient. We treat it trigeminal neuralgia to enormous doses to make sure there is no possible motion. There's a feedback loop we've created, and I won't talk about it today, which is it's called Plato's cave. It's a cave is a computer-augmented virtual environment to say, okay, to look at the patient's data set and have visual cues in terms of how do you, where is it possible intuitively, where's the best pathway to hit a target with a surgical procedure, or intuitively, does that match the treatment planning system that we're trying to develop? We also developed sort of a visual screen in the operating room where you can move these images around by hand gestures and voice commands. So in conclusion, we feel that radiation oncology may have some of the tool sets that may apply to the surgical navigation system, especially below the head and neck area where there hasn't been as much development. So this is creating sort of a process map of what you do with the imaging data and how you interact with it from a radiation therapy standpoint. I won't go through all the same type of planning process can be developed for a surgical planning or surgical idea of where's the best person to put, where's the best entry point into the patient's body for a surgical procedure. Would it help if I rotated the patient a number of degrees, knowing that everybody's anatomy is slightly different? These are similar things. So as I said before, oftentimes best information comes from sort of silos of expertise, crosstalk between different areas of expertise. So this is sort of the OR Dr. Lumsden's probably luxury OR of the future. You know, we live over in the annex if you ever want to come by there, but wear a flak vest and, you know, it's... So when I talk about tagging and labeling, one of the most difficult procedures you have to do is, say, a Whipple procedure where you take the head of the pancreas out and you do a lot of anastomosis. And one of the important things is, for instance, where is the common hepatic artery and the left hepatic artery, because there's often variance. So being able to tag and label the data set before you interact with the data set, not only virtually, but in real time in the operating room, gives you some clues as you rotate this image around, you'll be able to see how the data set changes and where those arteries and veins are. And other just 3D processing has become more and more common. The most important thing, just like it is in the oil industry, is try to get as much data as possible. Data is acquired from a CT scanner at every 0.625 millimeters. When they show you the images on a screen, you only see them at every 5 millimeters. So one of the things we do is suck all the data in when we do sort of our processing to give the best possible image and tell us where we need to be within the patient's body. So again, if you think of the patient as a data cube, you want to fly into the data cube to a location where your disease is, where your problem is. Dr. Lumsden's jet, he's very... So you say, the question is where's Waldo? You know, where's the problem? And you want to zoom into where Waldo is. Some people say, well, who's Waldo? They don't, you know, but if you haven't seen the comic book, Waldo is... So there's Waldo, okay. So here's an example of a sort of this is a patient that is gonna, from the ENT department, we're gonna say, well, when they do a cochlear implant, they usually remove a lot of bone. They said, can we create a pathway where we can fly through the mastoid air cells to get to that area of a location where we want to do the cochlear implant? And we said, well, you know, we just sort of tried this and said, so you can see this is just the film saying this is, we just sort of did it when they came in the room. But we created a glide path for them, just like you're going to create a glide path going into the patient's body to get to the target. As you fly through the patient's mastoid air cells is what we're doing now, and then you'll get to the inner ear, and you'll see the fidelity of the image as you get closer. The fidelity of the image improves, the more data you use. It's like, you know, it's always best to have the most amount of data. It's like you don't make a financial decision, only know 12% of the data or every 5 millimeters. We also use pattern recognition algorithms to say, okay, has there been a change we don't understand in the patient? And try to compare it to the initial set of data. These are just some of our mobilization devices. This is the camera you'll see in the room that does a projection onto the patient. It's a stereoscopic camera that is achieved from the patient's CT data set. So he should be in that exact location, or she should be in that exact location of the room. There's like 20,000 points that have to line up onto the patient's body. Here's a lung nodule in a volumetric space that we think we should be able to hit fairly easily. Here's sort of a picture of, you know, can we create a virtual data set and superimpose it into the patient's body? This is from Lost in Space. So you can see the data set going into the patient. It's been defined, tagged, and labeled, and then you're going to interact with that particular data set. So these are just some of the ENT residents that work in the K with us to do educational things. A lot of the stuff we do is connected to a three-dimensional printer. They created educational things for the other residents. Here's Dr. Grossman in neurosurgery. Now Dr. Britz is now chairman. But this resident here is interacting with, we have a connect box where we interact with the data, move the data around. And this is that table there is a surgical, we try to make it into a surgical table, whereas it's developed by a guy from MIT, where 4 different people at one time can interact with the data set, a multi-user table, and interact and move the patient around and say, you know, what's the best angle to do things. Economic model can be based for surgical pre-planning and surgical decision-making, and adaptive surgical procedures can probably be based on the sort of the radiation therapy model. That's created by multiple beams coming into everybody in radiation therapy. Alan is happy. And then I've got one last, you know, Dr. Lumsden drives his crew very hard. A lot of people I've heard in the hallway say he may not have a heart, and he fell asleep during when he was here. And this is just to prove he does have a heart. And this may be a HIPAA violation, but that's sure enough. Dr. Lumsden, his heart is working well.